I would like to thank the organizers of CMAI for inviting me to talk about this topic, adult immunization. I also would like to thank Ms. Rosie from our institution for coordinating this. So for today's, I bring today's talk. Before I start, I bring welcome from greetings from our institutions, Believers Church Medical College in Thiruvalla. So when I look at adult immunization, we always wonder, why is it so important now? If you look at the pediatric immunization world across, it's such a well-funded, well-organized program. There's so much clarity. But that's not the same with adult immunization. So in our department, we've been looking into it and we've been thinking we need to emphasize this more. So for today's talk, first I would like to look a little bit into the history of vaccination. Then we look at some of the vaccines little more in detail, what we commonly use in adults. So also we would look at that subset of population who need to be catered differently, those with altered immunocompetence. I don't know how many of you recognize this person in this picture. He is Edward Jenner. He is the father of immunization. The story goes like this. In 1796, he noticed that the milkmaids who've been coming in contact with cattle regularly, they got cowpox, but they never got smallpox. So this made him think that there's something in them which is making them immune towards smallpox. So what he did was he took the material from the source of this cowpox scabs and introduced it under the skin of his gardener's son. He was an 8-year-old boy named James Phipps. He did have cowpox after that. He came out of it within 1 week. 2 months later, he took the materials from the source of those with smallpox and inoculated it under the skin of James Phipps. And as expected, James Phipps didn't have smallpox. So this process, he called it vaccination. So vaccination comes from the Latin word vaca, which means cow. So this is Edward Jenner giving vaccination to children. If you look back in 200 BC, Chinese doctors also used some dried cowpox scabs. However, this process was not successful procedure because there was so much of mortality associated with it. It was just 1,000 years later when Edward Jenner introduced smallpox vaccine. Thereafter, 100 years later, Louis Pasteur brought out rabies vaccine. After that, we have had so many vaccines available for us, the last being COVID vaccine. There are over 33 vaccine preventable diseases. But when we think of vaccinating someone, what we should consider would be the age of the patient, the comorbidities, the immune status of the patient, and also the endemicity of that particular disease to make a decision. Now, why do adults need vaccination? One is that it is possible they have missed out vaccination during their childhood, or else it is to boost the efficacy of the childhood vaccine, because as they get older, there's some loss of immunity and they have other comorbidities making them more susceptible to these infections. So it is important to vaccinate them. So also when you vaccinate the adults, you are improving the herd immunity. Now, adult immunization is not without challenges, the main being inadequate funding for vaccine. Now, this universal immunization program for pediatrics, it was introduced way back in 1978. So I was just looking at the data. Almost 2.7 crores infants are being vaccinated every year, and almost 10 crore children like below the age of 5 being vaccinated. So that's a huge commitment from the government for the children. And it's a well-funded program. That's not the same with adults. And there's lack of motivation from the healthcare provider and the patient. I wonder, so many times we have patients in the ward, in the ICUs. Maybe they are there because of pneumonia or some other infection. How often do we plan on discharge and advise on vaccination when they come back for their follow up in the OPD? I can say that I don't do it all the time because I don't think of it as a priority. But when you see the cost incurred by that patient just because they had that infection, sometimes something which was preventable, this is a cost effective method which we use in adults. It is not without cost. Just a simple vaccine like influenza and the pneumococcal, if you have to give it together, it comes to almost 5 to 6,000. So it is expensive. So also when you look at the healthy adults, to get them into the public health system is not that easy. Public health has come out with this concept of life course immunization. That is a concept of vaccination providing protection across different stages of life. Now, if you look at the guidelines, the main guidelines are given by the ACIP under auspices of CDC. That is Advisory Committee on Immunization Practices. WHO has its own guidelines. And India, we don't have an official guideline. However, the Association of Physicians of India, along with the various bodies, like they join together with the Cardiology Society, with the Infectious Disease Society, nephrologists, gynecologists, oncologists, all of them came together and they made an expert panel guideline. They've taken most of it from ACIP. And in 2024, during the API, the conference, they had released this guidelines, and it's like a 80-page leaflet, which really gives in detail all that we need to know about adult vaccination, and most of it is taken from ACIP. This is how ACIP guidelines look like. They bring it out every year, and they color code it to show according to the age, according to the comorbidities, conditional recommendations, so also according to the various immune status. The Indian consensus recommendation also tried to bring out a similar pattern for the Indian population. The list is exhaustive, so we won't be able to touch upon each and every vaccine. For today's talk, I will look at that which is most relevant for us and that which we use commonly. First, let's look at influenza vaccine. I'm sure this would be the vaccine which we are using the maximum in adults. Now, we know that it's an annual vaccine. Why is it an annual vaccine? Because the influenza goes through this continuous antigenic drift and shift. Drift is a mild change in the genetic makeup, where a shift is a major change in the genetic makeup. So because of this drift, they need to bring out new serotype every year. So WHO gives a recommendation saying what is the next serotype should be. Whereas when shift happens, the people they don't have immunity for that in the community. So it goes to the level of a pandemic. So that's what happens when a shift happens. Now, if you look at the timing, the places where they have proper season, like the 4 seasons, I would consider like in North India, when they have seasons, we should vaccinate them before the winter months. So ideally, it would be around October or early November, late September. That would be the time for vaccination, around 2 to 4 weeks before the winter set in. If you look for South India, we look at the monsoon season. So April, May would be an ideal time for the southern states in India. Now, if you ask when is the time when the new serotype comes, usually it's around that September month. That is when the Serum Institute and Serum and all comes out with the latest vaccine. So currently what we have in our pharmacy is the 2024-25 strain. Now soon, in 2-3 months, we will get 25-26 strain. Pneumococcal vaccine, sometimes there is not much clarity about this. What we need to understand is the main difference between the polysaccharide vaccine and the conjugated vaccine. How are they different? Polysaccharide vaccine is a recombinant vaccine, which is very good. The immunity is good. It covers 23 serotypes. The conjugated vaccine is even better. Here, the polysaccharide antigen is conjugated to a carrier molecule, making the immune response much more robust and longer lasting. So, because of that, we give PCV 13 first and then 23. Now, they have done studies with 13 first, where they have given 13 first and then 23, and vice versa also. And the studies have shown that when you give PCV 13 first, followed by PPSV 23, the immune response is better. To make it simple, PPSV, the polysaccharide vaccine, what we talk about is commonly available as Pneumo 23 or Pneumovax 23. PCV 13, the commonly called Previna 13. So here we give it 1 year later, the polysaccharide 23 serotype, followed by 5 years later, PPSV. Now, after the age of 60 and 65, they have to get one more dose at that time. The only difference with the immunocompromise, like HIV patient, post-plenectomy, post-transplant patient, the gap between CV13 and PPSV 23 is only 8 weeks, whereas in the other case, it was 1 year. Let's move on to hepatitis B vaccination. All healthcare professionals should have received hepatitis B vaccination. So also those who are working with communities where with high risk, they're dealing with people with high risk behavior. So also if they are in a situation where they are going to undergo medical procedures and all, it's always good to have hepatitis B vaccination. What we have is the recombinant hepatitis B vaccine. In the West, they have hepatitis, the Heplisab. How is Heplisab different? Heplisab, it is recombinant with an adjuvant molecule attached to it, making the immune response even better. So they don't need 3 doses, they need only 2 doses. So also about the PCV, which I was talking about, the previous one, abroad they have PCV 20 now. We don't have it yet in India. Once we have it, we'll move to that. If it's PCV 20, you just need 1 dose and you don't need to follow up with that. Same with this Heplisab. It is a shorter immunization course. It's just 2 doses. Now, how is hepatitis B vaccination different in adults? If someone has to get hepatitis B in infancy, majority of them would go into a chronic carrier status. That's not the same with adults. If hepatitis B was acquired in adulthood, majority of them would become seronegative. Now, there would be some people in the community who have had subclinical infection and they have already achieved immunity. So, what should be doing before giving vaccination? Ideally, you should check hepatitis surface antigen and anti-HBs antibodies. Now, if HBsAg is positive, they are anyway infected, they are not candidate for vaccination. If anti-HBs antibodies are present, they're already immune, so they also don't need vaccination. Now, in a small subset of patients, we even check anti-HBc. I'll come to that later. So when you give vaccination 0, 1, and 6, 2 months later, 1 to 2 months later, we should check the antibody titers. If antibody titers are about 10 international units, that is sufficient. If it is not, then you have to revaccinate them and take through the whole 3, the series of the 3 injections. And at the end of it, you will again check the antibody titers. If it's still not sufficient, we call them non-responders. And these are the candidates who need immunoglobulins if they get exposed to hepatitis B. Now, if like our medical students, when they come, we always check the anti-HBs antibodies. So in their case, if it is not sufficient, we revaccinate them once again and check it. So how is it different for dialysis patient? Dialysis patient, we expect them not to mount enough immune response. So we give double dose. So instead of 20 microgram, you give 40 micrograms. And either you go through a 3-dose series or you go through a 4-dose series. Most of the dialysis units follow the 4-dose series of intensive way of vaccinating 0, 1, 2, 6 months. Now, I told about the small subset of patients where anti-HBC is positive. What does that mean?
Hello.
Hepatitis surface antigen is negative, anti-HBs antibody is negative, only anti-HBC is positive. What does that mean? They have had remote infection. However, it didn't mount enough immune response. So the antibodies didn't come in. And anti-HBC is positive, showing that they had remote infection, or it could be an occult infection. So here we have to give one booster dose and check the antibodies 1 to 2 months later. Here the cutoff we need to achieve is much higher. It's 100. If it is less than 100, we give the full HBV vaccine series. Moving on to hepatitis A vaccination. Who are the candidates who should receive a hepatitis A vaccination? Probably those who go into hostels, if you're traveling to places where the hygiene and sanitation is poor. In fact, for the international travelers, when they come into India, they are supposed to get hepatitis A vaccination. If it is an isolated hepatitis A vaccine, it's a 2-dose series with 6 months apart. But you have combination with hepatitis B, the twin tricks. If we are using the combination, you follow the hepatitis B schedule, 0, 1, and 6. Now, we get lots of people who have to travel abroad and they have to finish all their vaccination pretty quick. And they have to have their titers, everything ready before they go. So they have this option of accelerated schedule. According to CDC, you can go through this 0, 7, and 21 days. Look, so within 3 weeks to 4 weeks, you finish with vaccination, followed by a booster 12 months later. Now, Tdap is something, the DPT which they give in childhood, till around 11 years of age, obviously they would be under the pediatricians and they would be meticulously giving the vaccination. But after 11 years, at 11, you are supposed to get one, that 10 to 11, you get Tdap. Thereafter, every 10 years, we are supposed to get Tdap or TD. The initial should be Tdap, follow-up can be either Tdap or TD. But what I often see is people would come to the healthcare only when they have a wound. But even that we can utilize as an opportunity to vaccinate them. So how do you take care of someone who has a wound? If it is a minor and clean wound, if they have already got vaccinated, if the duration is more than 10 years, they need to get again a Tdap or TD. If it is a major wound, unclean wound, then the cutoff is just 5 years. If the last vaccination was more than 5 years, we need to vaccinate them again. If these are the people who have never been vaccinated, then they have to go through the full 3-dose series, the 0, 1, and then 6 months, the whole series they have to go through. Now, those who have severe wound, we have the option of even giving a post-exposure for the prophylaxis. You can give immunoglobulins. There, the dose is just 250 international units, whereas for an active case of tetanus, the doses are much higher. Now, MMR, I don't know about the other states. In Kerala, they have a government fever surveillance program, which has been quite active. So all of us are part of that. And every hospital intimate them every case of fever with rash. irrespective of the etiology. Even it be drug rash also, because they don't even want to miss one case, we report to them, and the government would collect the sample and take it to the central lab and would get it tested. And the last 2 years, we have had so many cases of measles from our own institution. And if you look at the Kerala statistics, it is alarming rates of measles. So somehow we haven't stressed enough to give vaccination in adults. So also there is a possibility that, so we do take the history of vaccination. Many of them can't remember. So when we had discussed with the pediatricians, in fact, they need, most of them follow that two. I'm not the expert at pediatric vaccination, but what the pediatrician said was they are supposed to get a booster after the 2 doses, which most of them don't. So that could be a reason why they are coming down with measles. So the recommendation in adult is 1 dose if they are born after 1957. Now, why this golden period of 1957? It is assumed that if you're born before that, you have natural immunity. So that is the cutoff taken. What about someone in the reproductive age, ladies in the reproductive age? Now, we know that if a pregnant lady gets measles or rubella, fetal outcomes are devastating. So, ideally, they should get vaccinated. And this is contraindicated in pregnancy. So, they should get vaccinated before they plan pregnancy, at least 3 months before they plan pregnancy. For health personnel, whether you're born before or after, the ideal way to go about in adults would be looking at the evidence of immunity. You can check the IgG levels of measles, mumps, and rubella. And if it is not sufficient enough, they can go through the either the 2 dose of MMR or at least 1 dose of rubella. HPV, human papilloma virus, has gained so much attention in recent years. All of us keep thinking about the CS cervix prevention, but we should remember it's not just CS cervix, it's vulval cancer, vaginal cancer, anal, penile cancer, genital warts, and also the head and neck cancers like the oropharyngeal cancer. Now, there are various serotypes away. We have this 4 serotype covered and the 9 valent. So we usually advise 9 valent, which has more cover. So the 4 one would just cover 6, 11, 16, and 18, those major serotypes. But if you cover others, they have protection against other diseases also. Now, the timing, the advice is to give HPV before their first sexual exposure. So usually we can start at any time after the age of 9, and the recommendation is till 26 years of age. But now there's a conditional recommendation from 27 to 45. The rationale behind this is, even if they have acquired one serotype, the vaccination can probably protect them against other serotypes. And according to the timing, if the child gets vaccinated before the age of 15, you need only 2 doses. Above the age of 15, they'll need 3 doses. The only problem is that it is quite expensive. Gardasil, that 9 valent, is almost 10 to 11,000. Now, varicella vaccine. All of us are well aware that varicella in adulthood is not a simple disease with just quarantine and getting out of it. They can have multi-system effect. We had a lady with ARDS, encephalopathy, she had such a stormy course in the hospital, and after a prolonged stay in ICU, she came out. So it's always good to vaccinate an adult if they haven't had varicella in the past, all the more if you are a healthcare personnel. But having said that, mostly the people who come to me for varicella vaccines are after the exposure. They panic and they come. So when they have exposed to someone with chickenpox, so that means they have seen the vesicles. Even 2 days before that, those people would have been infected. So they are already in the incubation period. So what is our advice? Yes, we would still advise. CDC says you should advise vaccination, but we should tell they may have a breakthrough infection still, or even if they have, it may be a mild infection. But in clinical practice, what I've seen, whoever we have vaccinated, most of them, I mean, almost all of them never had varicella infection. But the other problem, what I see is they would take the first dose because they are in a state of panic. And next 1 or 2 weeks, they realize that they didn't have the infection and then they forget about the second dose. Once they have taken, might as well take the second dose and complete the vaccination schedule. Because otherwise, many of them who come to me are those who have taken one vaccine at some point and then they haven't taken the second dose. The ideal recommendation for someone who has been exposed would be getting the titers of varicella IgG. If IgG is positive, they are immune, they don't need vaccination. If it is not there, depends on the immune status. Now, someone with normal immunocompetence, we would advise vaccination. But who are the ones whom we advise immunoglobulins? Those who have immunocompromised state, or pregnant lady, because in pregnancy you can't give varicella vaccine, and infants who are born to a mother who had chickenpox just before delivery, the last 1 week. So they need immunoglobulins. Now, recently I got call from one of the mission hospitals where pregnant lady, they wanted to give immunoglobulins, but if it was not available, then what do we do? The alternate recommendation is from the time of exposure, you calculate 7 days and then give a course of acyclovir. However, giving immunoglobulin is way superior. Zoster, we are seeing more and more patients coming with zoster, and the post-herpetic neuralgia is very severe and sometimes it's excruciating pain. So wherever they can afford, because again, the vaccine, what we have current, the latest one is the recombinant Shingrix vaccine, where we give 2 doses. The efficacy is very good. It's almost 80 to 90%. Only problem is the cost. So above the age of 50, it is a recommended vaccine. Something which has been intriguing for me is, why is it that chickenpox vaccine is not covering zoster and zoster vaccine not covering chickenpox? From what I read, what I could understand, what the way, because both are the same virus, it's just the different manifestation. However, chickenpox vaccine is made in such a way that you prevent that initial infection. Zoster vaccine is made in such a way that it will boost the immunity of the patient, that that quiet virus which is lying there will never get reactivated. Moving on to rabies vaccine, our decision depends on the category. Category 1 means they don't need vaccination because it's on intact skin. 2 and 3 would need both vaccination and immunoglobulins. Now, in Kerala, it has been a menace with rabies, like lots of children came down with rabies, and it has been a problem. So, the pediatric groups have moved ahead and they are talking about pre-exposure vaccine now. So this is the Indian consensus guideline. They say those who are veterinary students, those who go exploring caves, those who are working in labs with the virus, rabies virus, and traveling to countries where rabies is common, and even those who are regularly into jogging, walking into the countryside and all, they should be getting pre-exposure vaccination. Now, pre-exposure, you need only 3 doses, 0, 7, and 21. 21 or 28 days, 3 doses. Now, how do we see that it has been effective? Ideally, you should check the antibodies. So the recommendation for this pre-exposure is 6 months later, you check the antibodies, and thereafter 6 monthly for the first 2 years, and thereafter every 2 years you have to check the levels of the antibodies. And if it is less than 0.5, we have to give boosters to them. Now, even in post-exposure, depends on whether they have already been immunized. If it's a rabbit-prone wound, definitely the guideline says even if they have been previously vaccinated, initiate the vaccine. So what we do is we have the place where we send the antibodies are to Nimhans. So if someone has been vaccinated already, we send their serum for testing, but it takes at least 1 week for us to get the report. So meanwhile, we give the first 2 doses for sure, 0 and 3, and then take a call from there. The international guideline says if it's 0 and 3 is enough if they have been fully vaccinated previously. If you are using IM, it's a 5 doses, 0, 3, 7, 14, and 28. And if it's intradermal, 0, 3, 7, and 28, 4 doses. Now, who are the candidates who should be given only IM and not intradermal? Those who are immunocompromised, those who are on immunosuppressants or long-term steroids. For them, the advice is to give intramuscular and not intradermal. Now, just quickly look at the set of population with altered immunocompetence. The main concern for us is safety versus efficacy. Now, safety, when we talk about, it's the live vaccine. Is it safe for them? Are they going to have a breakthrough infection if you give that vaccination? On the other side, if you give a vaccine, is it going to be efficacious? Are they going to mount immune response? So most of the people with altered immunocompetence, we avoid live vaccines. So when we say live vaccine, mainly MMR, varicella, the nasal form of influenza, that is the live attenuated form, yellow fever, the oral typhoid is a live vaccine, BCG, smallpox, and rotavirus. Can they still receive it? Yes, in certain situations, in leukemia, lymphoma, and other malignancies when they are in remission. If chemotherapy has been discontinued for 3 months, persons with impaired humoral immunity or B cell deficiencies, they can receive varicella vaccine. In HIV, generally we take the cutoff as 200 because we feel after 200, they can mount immune response and it is safer for them to receive some of the live vaccines. Now, if you look at the timing for these people, if someone with the post-transplant on anti-rejection therapy, you wait till 2 months after discontinuation. If they are on immunosuppressants, 3 months after discontinuation. And if it is anti-B cell agents, the cutoff is larger, 6 months. If someone has been on immunoglobulins, they can still receive live vaccine. That's not an absolute contraindication. Now, if you look at the flip side, if someone has already received immunosuppressive therapy, when can you give a live vaccine? So, if they have already received it, wait for at least 4 weeks before giving a live vaccine, or at least 2 weeks before giving a non-live vaccine. If they are on high dose steroids, when we say high dose steroids, it's more than 2 milligram per kg of body weight or an equivalent of 20 milligram of prednisolone for a consecutive of 2 weeks. So you defer live virus vaccine for at least 1 month. Now, what is cocooning strategy? Now we realize that these immunocompromised patients, they can't receive all the vaccines. So what do? We vaccinate the family members. They sort of form a blanket around them, protecting them from infection from outside because those whom they are in regular contact with, they are vaccinated. So that is called cocooning strategy. Let's quickly look at these 3 set of patients. One is the HIV, the other is the post-bone marrow transplant and post-splenectomy patient. How should we cater to them differently? In HIV patient, main concern is live vaccine. Now, these are the vaccine irrespective of their CD4. We won't give it. The live intranasal influenza, oral polio, the oral typhoid, all these are the live vaccine. Now, BCG, there's a conditional recommendation. You have to decide the population. If the TB is very rampant, there is some conditional recommendation that they may still consider giving. Otherwise, it is contraindicated. But once the CD4 goes above 200, they can take yellow fever, MMR, or varicella vaccine. Moving on to those with post-stem cell transplant. How are they different? Before the bone marrow transplant, when they do the conditioning, you're sort of knocking off the memory T cells. So their bone marrow would behave as a naive bone marrow, like a newborn's bone marrow. So you have to go through the whole vaccination schedule all over again. So this is a recommendation by the Indian consensus statement. Various hematology societies have come out with, but all of them follow similar guidelines. So maybe there's slight difference in the timing. Mostly they say 6 to 12 months after transplant, they start the vaccination. And they have to take the schedule as they would do in pediatric age group. So also they have to finish the adult vaccination. However, these live vaccines, BCG, the live attenuated influenza, oral typhoid, and rotavirus, they are not recommended to them at all at any phase. So in our hospital, our hematology team, they call Raktam. So they have got their own vaccination schedule for the patients, and they have laid down all the timing and all the details for that. Moving on to post-splenectomy. So we have many of these patients under care for vaccination. So I would just broadly divide them into two sets. Either they have their splenectomy because of a trauma, road traffic accident, or it would have been a planned elective splenectomy, like someone referred from hematology for a refractory ITP or something like that. So if it is a traumatic splenectomy, there's no time. It's an emergency surgery. They have to proceed with the surgery. Our concern is mainly with the capsulated organism, H. influenza, pneumococcal, meningococcal. So also they need to get the influenza and Tdap. So for these people, you proceed with the surgery, and 7 days later, so before discharge, you can start the vaccination schedule. Whereas if it's an elective, you try and vaccinate them and try and complete as much as possible till 14 days prior to surgery. So after that, we stop all vaccination and then we restart only 7 days after the surgery. Earlier, they said 14 days after surgery, but now they say 7 days later also we can reintroduce the vaccine. What we should remember is PCV13 and meningococcal vaccine are not compatible to be given together. So we make a schedule for them, we plan it for them, and we put it in the vaccination card and give it to them so that they can follow the pattern. Now, the frequently asked questions for me are, one is, how many vaccines can you take in a particular day? Now, the answer is as many, but you have to look at the feasibility. Whether it's live, non-live, like I said, some of them are not compatible, like PCV13, meningococcal, they are not compatible. Otherwise, most of them are compatible. If they are already coming as a combination vaccine, like MMR, DTaP, you can give it, in two different places. So in effect, you are giving 6 vaccination in a day. But otherwise, if it is separate vaccine, you have to see that it should not be mixed in the same syringe. It should be in different sites. So I don't think it is feasible to give more than 4 injections in a day. But yeah, so there is no definite answer saying how many you can give. As we see this always when they have to travel abroad, when they have something for job, visa, and the time span is very short and they have to finish whole lot of vaccinations. So that's when we plan this kind of vaccination. Other is when you get one vaccination, when can you give the next vaccination? Now, there is clear guideline for live vaccines. The time given is 28 days. Give as many as possible on one day, then you wait for 28. Yellow fever, in fact, they say definitely 30 days. So that is the time gap given. So here, so this year I've been working on the adult immunization card for us. This was something which was there in our mind. And finally, just 2 weeks ago, we released it in our hospital. So this is how we made our immunization card. So we thought once we have this card, we as healthcare providers would be more motivated to take this up. And we got another card for the splenectomy patients also, so that we can plan out specifically for them. So here all the details are given, and here we can plan the next due date and schedule, because like meningococcal and pneumococcal, after the first 2 doses, then it'll come after 5 years. So even they will forget when it was. So if you write there, like someone is getting vaccinated now, the second dose, the next will come in 2030. So we write it down and give it to them. So finally, my take home points would be, if you're dealing with immunocompromised patients, you should be very careful with the live vaccine to decide timing. And you should always see safety versus efficacy when you decide vaccination for them. And whenever possible, you can give simultaneous vaccine as long as they are compatible. And you should think of the timing, that you give as many as possible on a particular day. But if it is a live vaccine, you give it after 28 days. So, as healthcare providers, it is very crucial for us and also for the policymakers and for the public to recognize the significance of the adult vaccination. And we should work together to overcome the barriers to immunization so that we can achieve a healthier and a resilient society. And we can keep these vaccine preventable diseases at bay, and we can have individuals who can enjoy a better quality of life. Thank you.